this presentation, I wanted to look at some of what I thought were some of the more important articles coming out in geriatrics over the past year. Not all of these are going to necessarily be applicable to our long-term care patients, but I think the majority of the people here are also going to be dealing with older patients in a primary care setting. So I think it will be applicable in that regard. Also wanted to, let's see if I can go back and put something in the comments. I've got I did a handout, and there's a QR code in some of the slides coming up where you can scan it, and I'm gonna put in the Google Drive link into the comments that you can pull up. And that's gonna have the citations for the articles, brief summary. It'll have I put some tables and visual abstracts in there, as well as the link to New England Journal Watch summary of the articles. All right, let's see. Okay, so again, there's the QR code for the handout if anybody's on their cell phone, as well as the Google Drive link. So the way I structured this, I kind of looked at topics where there were several articles that I thought would be applicable for that topic. And some of the big things that I saw coming out this year, there were several studies on falls, osteoporosis, dementia, anticoagulation. I know SGLT2s, probably not starting those on many of our nursing home residents, but I think they are becoming more widely used. And so I think we're going to be seeing more nursing home residents coming in on those medications. And I think there's some pretty interesting stuff coming out about them. I've got a potpourri section with articles. Actually, it's just one article that didn't fit into the other topics. And if we have time, a little bit on lipid management. So to start off with, in the fall section, I looked at things that don't work, and which was most of them, and what may be helpful. So the first two studies, both were looking at vitamin D, which I think has been has been something that's kind of been picked up in the lay media as something that can be helpful for falls. But as you'll see with both of these studies, really did not show any improvement. So for this first study, as a randomized trial, was looking at vitamin D supplementation and time to first fall or death. These were all adults over 70 years old, community dwelling, and all at baseline had a low vitamin D level. The control, one of the limitations perhaps is for the control, they did use a low dose vitamin D and not placebo. And then the intervention group, they used 3 different doses of vitamin D supplementation. They followed these patients for a couple of years, and at the end, again, found no fall prevention with the 1,000 milligram dose. And with the 2 higher doses, they actually showed that it could have an increased fall risk with those doses. And again, this is on some of these, we did have visual abstracts. So I've included those here and in the handouts. And again, those, you see a slightly lower hazard ratio, but did not meet significance. So this is another one that came out on vitamin D. This was actually, so the initial trial was the VITAL trial, which was looking at vitamin D and omega-3 fatty acids for cardiovascular events and cancer. But they did some secondary analysis, I guess, and looked at the vitamin D in relation to falls. They didn't look at death in this one, so it was over 2 falls or falls resulting in a doctor or hospital visit. So it was a much larger study than the previous one, so over 25,000 community dwelling adults, a little bit younger, a mean age of 67, and they had normal or low vitamin D at baseline. And since the initial trial was looking at cardiovascular events and cancer, that was one of the exclusion criteria of the initial trial. This one was placebo controlled, and instead of using the different doses of vitamin D, it used just the 2,000 international units daily. Followed them for a little over 5 years, and again showed no decreased fall risk with the vitamin D supplementation. Lastly, as far as what doesn't work, this looked at a multifactorial intervention for fall risk. And and they, instead of randomizing all the participants in this study, they divided it up between primary care practices. So each practice would do one intervention or the other. This one was looking at time to first serious fall, and it involved about 5,500 community dwelling adults, again over 70 years old, and it was adults that were at increased risk of falls. So for their control, they just said enhanced usual care, which was basically just counseling the patient on fall prevention, maybe giving them a handout about it. And their intervention group was what they called a multifactorial intervention. So what this involved was they had a nurse or some other office person who would have gone through some sort of training, and they would contact the patient, assess for fall risk factors, which could be gait problems, certain medications they were on, frailty. And then after they assessed the patients, they would institute any interventions that they thought may be helpful, such as physical therapy referral, medication adjustments, stuff like that. And they would follow up with the patients, set up follow-up doctor's visits if needed. And the maximum follow-up in the study was a little less than 4 years. And again, no significant difference in serious fall injury, hospitalization, or death. This, again, a visual abstract, and these are in the handouts as well if you want to go back and take a closer look later. This was a bit of a smaller study, so only 86 practices. What was it? About 5,500 adults. Okay, so most of the studies coming out, at least over the past year, really didn't show much that helped. This one wasn't necessarily saying that this was helpful, but I do think it's something that we should be considering. I'm sure most of us are anyway, especially in older adults, but that orthostatic blood pressure can affect your gait. This was a cross-sectional study and was looking at the association between orthostatic blood pressure and gait. It looked at a little over 4,000 community dwelling adults. This was a bit younger of a population than the other ones, a mean age of 62, and about 20% of the people they looked at had orthostatic hypotension. And what they were looking at was to see if that was associated with a spatiotemporal gait disturbance, and they looked at several different parameters to judge that, whether it be gait speed, stride length, I think was one. And they did show that the orthostatic hypotension was independently associated with poor gait, which they didn't look at falls specifically, but I think it's a reasonable assumption to say if it's going to be associated with poor gait, it's probably going to be associated with increased risk of falls. So just something to be aware of in your older patients. So, a lot of them are going to be on blood pressure medications. So something to keep in mind. Take-home points for falls, vitamin D supplementation and fall prevention education really haven't been shown to be that effective. And just to be mindful of orthostatic blood pressures in your older adults, as they can affect their gait and increase fall risk. Okay. Next up, you're going to look at a few studies that looked at osteoporosis. The first one here is going to be talking about treatment. I think, generally, most of the time people are getting taken off their bisphosphonate at the end of 5 years. The endocrinology guidelines, their recommendation is do the 5 years, do a holiday, drug holiday. And if people are at a high risk, you can consider extending it out farther. So this study was a retrospective cohort study, and it looked at the occurrence of hip fracture in women that were stopped at 5 years versus extended the therapy to 7 or 10 years. One thing I think is worth noting in the participants, it was a pretty large study, almost 30,000 women, an older population with a mean age of 71. But I don't really think it's, like I said, the endocrinology guidelines recommended considering further treatment for high-risk patients, whereas in this study, only 2% had a history of hip fractures, 11% any history of osteoporotic fractures, and only a little over a third had actually been diagnosed with osteoporosis. So, I mean, the way I kind of interpret that is these aren't really high-risk women. So the exposure was the length of bisphosphonate therapy. So all the women in the study had been on it for at least 5 years at study entry. And so they looked at women who stopped it at the time of study entry, those who were continued on for another 2 years, so 7 years total, and those who were continued on it for 5 more years, so 10 years total. They followed them to the end of those 5 years and did not show any significant difference in hip fractures between those groups. And the overall outcome was about a 2% 5-year occurrence of hip fracture throughout each group. The next study was looking at bisphosphonate use in atypical femur fractures. And one of the reasons that, at least in their introduction, the authors felt that this was an important study to be done was that I think the concern for atypical femur fractures has become a little more widely known in the past few years. It's becoming more of a concern for patients. And because of that, the prescribing of bisphosphonates has actually gone down, causing an increase in the frailty fractures. So in this study, again, it was a retrospective study looking at the atypical femur fractures. It was very large, almost 200,000 women over 50 years old. The vast majority were white, the majority were white, followed by Hispanic, Asian, and Black. Their exposure was oral or IV bisphosphonate therapy. And the therapy ranged from less than 3 months, so just barely being on it, to over 8 years. They followed them for 10 years. And what they were able to show was that the advantage you get from frailty fracture prevention significantly outweighs the atypical femur fracture risk. They were able to show a few risk factors that were associated with the atypical fractures. Increased age was one, Asian ethnicity, and chronic steroid use, which I think is understandable. One thing they did note was that as soon as patients stopped the medicines, the decline in fracture risk went down pretty quickly. This is the graphic representation of the results here. I think it is helpful to see. So the top line in each graph, your red triangle, is the number of fractures prevented. The blue one with the squares is hip fractures prevented, and then your purple circles are the atypical femur fractures. So then and it's looking at the Asian, white, and Hispanic women, and in all ethnicities, races, and throughout the course of treatment, the benefit is outweighed by the risk. Now, again, in the women of Asian descent, they are at a little higher risk. So once you get out to 10 years of treatment, you are kind of, these two lines are starting to close in on each other. And then I don't know if it brought it up in this article, but some of the other ones I'd read, one of the reasons they speculated that Asian women were at a higher risk was, I believe there's some bowing of the femur. So I didn't really look too deep into that, but just something to consider. All right. So one of the things that some of the feedback I got on this presentation was to go into a little bit on how we should be evaluating for these fractures, just things to keep in mind when we do have patients on these medications, especially when they're higher risk, if they've been on it longer, older age. Usually there's not going to be any preceding trauma to the fracture. The most common symptoms are going to be a persistent groin or thigh pain. You may also notice some limb shortening or swelling, which I think would definitely tip you off to something's not right, as well as some bruising around the area. On the imaging studies, so your initial study is just going to be a plain film x-ray. You're likely going to see some focal cortical bone thickening. And usually the fracture is going to be transverse on the lateral side. One thing that's important to keep in mind when you are working up these patients, if they have an atypical femur fracture on one side, you always want to image the other side, because in just over a quarter of patients, the other side's also going to be affected. And it may not be at the time of the initial fracture, but in the time following that, they're going to be at higher risk for the other side being affected as well. These are just some of the imaging studies. On the left, it's showing the complete fracture. Again, you're going to have a transverse orientation. It's going to start on the lateral side, and this side is showing this kind of medial spike in the bone. To the right, you can see an incomplete fracture. And you've got the cortical bone thickening here, and then this small lateral fracture line there. As far as management goes, the main thing is getting them off the bisphosphonate. Conservative therapy is probably not the best option, but it can be considered for incomplete fractures and just for your patients that, which I think may be more applicable for the nursing home patients, patients that just have multiple comorbidities and just are not a surgical candidate. And that conservative therapy involves calcium, vitamin D, and you can also consider one of the anabolic agents like teriparatide. Again, usually this isn't the best approach unless they're just not a candidate for surgery. Surgery usually has better outcomes. The take-home points for osteoporosis treatment. Generally, you're going to want to stop the bisphosphonate after 5 years in your low-risk patients. Again, high-risk patient, you may consider further treatment. And I didn't get into it here, but another consideration, could be using a different agent. The benefits of bisphosphonate use far outweigh the risk of atypical femur fractures. However, there are some certain risk factors that you may want to consider in your patients. And it's just important to be vigilant of these fractures in patients that have been on the medications and that are on them. And again, once the medications stop, the risk for having the atypical femur fracture goes down pretty abruptly. And I don't know, I guess, Megan, if I need to stop and address and answer any questions, let me know. I'll just keep going through unless you stop me. So next we're going to go look at a few studies on dementia. The first one here is looking at anticholinergic medications and risk for mild cognitive impairment. I thought this was pretty interesting because, for one, the list of anticholinergic medications they use is pretty extensive, and a lot of medicines that I wouldn't have generally considered anticholinergic. I believe the most common medicines prescribed that they counted as anticholinergic in the study were like metoprolol, atenolol, loratadine, which I would consider, but probably not that high of risk. And then I believe bupropion, I think was the other one. So ones that I generally would not consider to be anticholinergic. But this was a prospective study, looked for incidents of mild cognitive impairment in initially cognitively normal adults, as well as the effect on memory, executive function, and language. It started out with just under 700 adults with a mean age of 73. One thing, if you do look into the study a little further, this was a very well-educated population they were looking at. I believe the average education was 16 years, so mostly college-educated adults. The exposures they were looking at, anticholinergic medication use. They also looked at the apolipoprotein E and CSF spinal fluid biomarkers for Alzheimer's. and they followed these patients for 10 years. What they were able to show was that the use of these anticholinergic medications did increase the risk for mild cognitive impairment and decline in memory and language. I guess it did not show a significant decline in executive function. And this effect was amplified in the patients who had either of the biomarkers present for Alzheimer's. And it did show some dose-dependent response where a higher anticholinergic medication burden was more likely to have increased risk of mild cognitive impairment. This is just the graphic representation on top. So this is looking at the apolipoprotein E and the CSF biomarkers on the right side here. And on each of them, those that are not on the medicines and negative for the biomarkers have the slowest rate of progression. Those that are on the medicine and have the biomarkers both have the fastest rate. And the ones that either are on the medicine and not have biomarkers, or have biomarkers not on the medicine, are kind of in the middle here. And this is looking at the memory and language, and it's basically the same thing. When you have medicine and biomarker, you're at the highest risk. When you don't have either, you're at the lowest risk. Next is a study that looked at the association between cardiovascular risk and cognitive decline. This was a longitudinal study, and it, in addition to cognitive decline, it also looked at structural brain differences. It followed just over 1,500 initially dementia-free adults. The mean age at the beginning of the study was just under 80 years old. And it looked at increased cardiovascular risk based on the Framingham risk criteria. Now, one thing to note, they only assessed for the cardiovascular risk at the baseline. They didn't reevaluate it throughout the study. They followed the participants for up to 21 years, and were able to show that a higher Framingham risk score was associated with a faster decline in cognition, episodic and working memory, and perceptual speed. And they did show significant brain changes on MRI. And I think, as far as dementia goes, we really don't have a lot of good medicines for it. I mean, we've got a few, but nothing to really, we can slow the decline, but we're not stopping anything. I think this just kind of amplifies the importance of addressing the modifiable risk factors, hypertension, diabetes, because a lot of people are getting the vascular dementia in addition to Alzheimer's. So trying to make a difference in the factors that we can address. And these are the graphs for that study, and it's breaking it down into the low, medium, and high risk cardiovascular groups, and whatever area you're looking at, whether it be cognitive function, memory, speed, or perceptual speed, working memory, the high risk group is going to have the faster rate of decline. All right. Next is a study that looked at the association between delirium and cognitive decline. This was a meta-analysis looking at long-term cognitive impairment following an episode of delirium. It looked at 24 studies, which involved surgical and non-surgical patients with delirium. Of the participants, there were just above 3,500 who had delirium, and they were compared to about 7,000 without. These were older adults, mean age of 75, and they were followed for about 2.5 years. They were able to show a significant association between delirium and long-term cognitive decline. And one thing the meta-analysis noted was that in all of the studies, they showed worse cognitive outcomes in patients who had experienced delirium. Now, obviously, we don't try to make our patients get delirium. As a lot of times it's out of our control. One thing I did see that I thought was worth noting in some of the commentary about this article was maybe something to consider if we're an older adult that's thinking about an elective surgery, just because the post-operative period is a high-risk time for delirium. So if it's maybe something worth considering and talking to the patient about, if it's surgery that is elective. And this one I think is probably the most applicable for nursing home patients because it was studied in nursing home patients. This is looking at taking patients off of acetylcholinesterase inhibitors when they have severe dementia. This was a retrospective study looking at all-cause events, which included hospitalization, emergency room visits, and death, as well as serious falls and fracture. Looked at about 37,000 nursing home residents over 65 years old who had severe dementia, and they go into the study about how they assess they had specific cutoffs for what warranted severe dementia. And all of the patients were initially on an anticholinesterase inhibitor. The exposure was looking at the residents who had the medication had been stopped with. The follow-up wasn't that long, less than a year, but they showed no significant difference in the all-cause events in the adjusted model, and they showed significantly lower falls and fractures when the medicines were deprescribed. And here's the results from that. So again, the unadjusted model did show a higher rate of the all-cause events in the deprescribing group. But once they adjusted for comorbidities and other things with the residents, there was not a significant difference in the deprescribing versus the patients who were continued on the medicine. And in either model, the unadjusted or adjusted, those who were taken off the medicine had a lower rate of fall and fracture, which I think is a pretty important thing to look at in nursing home residents. And just as an aside, the American Geriatric Society, one of their choosing wisely recommendations is when you do prescribe these medications, make sure that you are periodically assessing the cognitive benefit and assessing mentions here adverse GI effects. I think, like that the study we just looked at said, you also have some increased falls. And so if somebody is falling, that may be something to kind of think about if they are on these medications, maybe one that would be worth taking off if you don't feel like they're getting any benefit from it in regard to their dementia. So take-home points for dementia. You want to be mindful in prescribing anticholinergics in older adults. That does seem to have some association with memory loss as they get older. You want to appropriately manage these patients' cardiovascular health. There's not a lot right now we can do once somebody gets dementia, but making sure that we're addressing cardiovascular health is something that's important as far as preventing dementia goes. And then in patients who are severely demented, it's worth considering stopping their anticholinesterase inhibitors. Okay. Next, we're going to look at a couple of articles on anticoagulation. I thought this one was really interesting. This was a retrospective study looking at patients who were initiated on DOAC, so direct oral anticoagulants, your Xarelto, Eliquis, Pradaxa, versus warfarin, and to see, and it looked at outcomes of ischemic stroke, bleeding, and a net clinical benefit composite score. They were looking at almost 16,000 nursing home residents. So they all had non-valvular AFib. They were all anticoagulant naive prior to the trial, so had not been on any anticoagulation for at least 6 months. The median age was 84, so it was a pretty old cohort they were looking at here. Median CHA2DS2-VASc was 5. Again, the exposure was a DOAC initiation versus warfarin. Not a very long follow-up, so 124 to 212 days. But they were able to show that DOACs were associated with lower mortality and overall less adverse effects. One thing that was noted in the study was in their review of the patients, incorrect dosing of the DOACs was pretty common, and it was associated with negative outcomes. So making sure for these patients to dose the medications correctly. And that can be, based on weight, renal function, a number of things, depending on which of the medications it is. This is the graph from this study. And as you can see, looking at apixaban or Eliquis, it actually had a slightly higher risk of stroke than with warfarin, but significantly less bleeding. And then all three of the medicines, the apixaban, dabigatran, and rivaroxaban, all has significantly lower mortality and the composite score. And this is just breaking it down into the different dosing. Nothing that I think is that surprising here. When the medicines are overdosed, which is to the left here, you're going to have higher risk of bleeding. When they're underdosed, you're going to have higher risk of stroke. So just emphasizing the importance of dosing the medications correctly. Next is a study that I thought was, again, pretty interesting. And it kind of, whereas in the last study, they made the point about making sure we're dosing these medicines correctly. But I know in a lot of patients, there's concern about giving them whatever their full dose of the medicine is based on a number of factors. So this study was looking at edoxaban, which is another DOAC. I don't know about y'all. I've never used it. I don't see it used commonly around Tuscaloosa. One of the issues with it is if the patient has a creatinine clearance, I believe above 95, you can't use it because they, clear it too quickly, so you don't get the benefit. So it's kind of an oddly dosed medicine. But anyway, this was the pharmaceutical company sponsored this randomized controlled trial, and it was looking at a composite of stroke or systemic embolism and major bleeding. It was Japanese adults, all over 80, non-valvular AFib with an elevated CHAD score, and they had to have some sort of contraindication to the recommended dose of anticoagulant. And I don't have them sitting in front of me, but I know some of the main ones were a history of major bleeding on the anticoagulant, significant renal impairment, I believe with a GFR less than 30 or 15, chronic NSAID or antiplatelet use. Anyway, patients that you would reasonably have concerns about starting on an anticoagulant. This was placebo controlled, and the intervention group got the edoxaban 15 milligrams daily, whereas the normal dosing for it's going to be 30 to 60 milligrams. However, there is a 15 milligram pill on the market. So if you did want to use this lower dose, you wouldn't have to be splitting the larger pill. They treated the patients for 466 days on average and did show a significantly less strokes and systemic emboli in the treatment group with no significant increased bleeding. As we can see over here in the visual abstract, there was a higher percentage of bleeding in the edoxaban treatment group. And some of the commentary I saw in this article was saying that it may have just been a bit underpowered to find significance in bleeding. If it had more participants or gone on for a little longer, it is likely that bleeding would have reached significance. But in the study they presented here, there was not a significant increased risk of bleeding. And as far as death goes, there was no significant difference between either group. But again, that was not one of the primary outcomes. I thought that was a pretty interesting, because I know, in my brief experience working in nursing homes, one of the concerns is always, starting these older people on an anticoagulant. I thought that was good. I guess my hope is that maybe some of the more commonly used DOACs will be put through similar trials so that we can have a little more guidance on these very old patients who need anticoagulation. All right, so take-home points for that. In general, DOACs are going to be safer and more effective than warfarin in nursing home patients. but it is important to try to prescribe at the correct dose. And we already kind of went over the edoxaban. Okay. So getting towards the past the halfway point here. I don't know. I think everybody's kind of starting to use SGLT2s more and more now. I think it's pretty exciting, all the new information coming out about them and just all the new indications. Again, this isn't necessarily geriatric specific, but I do think, the patients that are being started on them are going to be becoming more, they're going to be becoming geriatric. So making sure we're getting familiar with them. I think as everybody knows, they were initially put out for diabetes, then they got the heart failure indication, and we may be getting more indications soon. So, and these are just some of the more common ones that are on the market. You got your canagliflozin or Invokana, the empagliflozin or Jardiance, dapagliflozin, Farxiga, and one of them that some studies are coming out more recently is this ortugliflozin or Stiglatro. I'm not as familiar with that one. There is some new data coming out on it. Just a little bit of review from previous years. Like I said, initially these were all studied in diabetic patients exclusively, but in the original trials they were looking at cardiovascular outcomes, and I've got the different outcomes here in the table, and the highlighted ones are where they showed significance. So we've got significant improvement in heart failure hospitalization in all of the patients. Their empagliflozin does show some all-cause mortality benefit. And then you've got the cardiovascular death and CHF hospitalization benefit in all of them but the ortugliflozin. And then the top outcome here is the cardiovascular composite score. The canagliflozin and empagliflozin were both superior, and then the other two were not inferior. So that was kind of where it all started. And they also were looking at renal outcomes in these trials. So for canagliflozin, they actually did a separate trial, the Credence trial, whereas in the other, the empagliflozin and dapagliflozin, they pulled the information from the original trials that we looked at on the previous slide. All of the outcomes, the renal outcomes were all a little bit different, and I've got them listed over here. So it's not quite comparing apples to apples, but in each of the trials in diabetic patients, type 2 diabetic patients, they showed significant benefit, renal benefit with these medicines. And just a brief review on how these medicines work in the kidneys. It blocks the sodium glucose link transporter number 2 in the tubular lumen, which decreases sodium reabsorption glucose reabsorption as well as sodium. So as we see in the little figure here on the right, the decreased sodium reabsorption helps prevent the vasodilation of the afferent arteriole, and similar to the effects of the ACEs and ARBs, this reduces the glomerular pressure and helps preserve the glomerular filtration rate. And obviously not going to go through all of this, but I think it is worth noting in the most current American Diabetes Association guidelines, if we look over here on the left side, especially in your patients, diabetic patients with atherosclerotic cardiovascular disease, heart failure, CKD, these SGLT2 inhibitors are considered some of your first line therapy after, of course, metformin, assuming that their renal function is adequate for metformin. All right. So following those trials where they were getting these significant benefit for cardiovascular outcomes in diabetic patients, they started to study non-diabetic patients as well. So the first one that came out was the DAPA-HF trial looking at dapagliflozin. And this is heart failure with reduced ejection fraction, so systolic heart failure. In this trial, the average ejection fraction was 31%, and the dapagliflozin showed a significant decrease in the cardiovascular composite as well as hospitalizations. If you look here, cardiovascular death, the hazard ratio and the confidence interval didn't cross 1, but something about how the study was set up, it was not set up to assess for cardiovascular death, so we really can't imply significance from that. Anyway, this year, the empagliflozin trial, looking at the same thing, came out, and it again showed a significant decrease in hospitalizations and the composite, but not a significant decrease in cardiovascular death. Following both of those, this came out. So this was a meta-analysis looking at both trials. So combined about 8,500 people with a heart failure reduced ejection fraction less than 40. And back, I guess, I'm no statistician, but by looking at both the trials, they were able to show a reduced all-cause and cardiovascular death, decreased hospitalization, and decreased serious adverse renal outcomes and heart failure with reduced ejection fraction. So, both the trials by themselves didn't show significant cardiovascular death reduction, but when the data was combined in the meta-analysis, apparently they were able to show some significance. And that's represented in the graphs here. We won't go through all of this. One of the, I guess, the newest trial to come out looked at dapagliflozin in patients with chronic kidney disease, regardless of whether or not they had diabetes. So trying to get another indication for the medicines. This was, pharmaceutical company sponsored, obviously. It was a randomized controlled trial. And again, the renal outcomes all kind of varied between the trials, but for this one, they looked at a composite of a sustained decline in GFR of over 50%, progression to end-stage renal disease, or death from a renal or cardiovascular cause. It was a large study, 4,300 people. And this one thing that's important to note, it's chronic kidney disease with proteinuria. Mean age was 62. The average GFR was 43. About 2/3 were diabetic. And the vast majority, so over 95%, were on an ACE or an ARB, which, in these patients, they were pretty much on the best first-line therapy for chronic kidney disease. They followed them for about 2.5 years, and they were able to show a significant decrease in incidence of the primary outcome and a relative reduction in overall mortality. So this is the graphs here. But one thing, and this kind of goes for all the indications, but especially as these medicines are getting more and more indications, they all are still branded, so they're all still quite expensive. And so I think it's worth looking at the cost. So in this trial, the number needed to treat for the primary outcome, which was again a composite of progression to end-stage renal disease, decrease in GFR, and cardiovascular or renal death, the number needed to treat was just under 19. So the annual cost of this medicine for one patient is about $6,300. Now that's cash price. They are pretty well covered by insurance, but just if they were paying cash, the average price would be about $6,300. So the cost to prevent one of these primary outcome events over about a 2.5-year span is $284,000. So a lot of money anyway, something worth considering with medicines. Some of the upcoming studies, as you can have probably guessed from the slides we've just looked at, empagliflozin they're also looking at chronic kidney disease with or without diabetes. So that should be coming out probably next year. Two of them that I was pretty excited to see the results of are the dapagliflozin and empagliflozin in heart failure with preserved ejection fraction. because, right now we really don't have any medicines that are shown to have a mortality benefit in diastolic heart failure. It's pretty much just controlling blood pressure and diuresing them. So I think if these do show a cardiac mortality benefit in these patients, I think that'd be something pretty exciting. So we'll see. When you are prescribing them, there are some safety considerations. One that's been pretty well publicized is increased risk of UTIs. Although there was something that came out this year saying they kind of reviewed the prescribing data and showed that maybe there's not that significant of a risk with them. Although anecdotally, myself talking to other physicians, they've had a few occurrences of some pretty significant UTIs on these medicines. One thing that's important, encouraging people when they're on the medicines to make sure they fully empty their bladder when voiding. By far the most common issue I've had, especially in female patients, is the genital fungal infections. I don't know about y'all, but I mean, by far and away, the main reason I have for having to stop these medicines is that. Again, one of the pretty well publicized concerns with them is amputation risk, but the FDA actually removed that warning from canagliflozin last year. So, once the initial, I believe the initial trial, the Canvas trial, had that higher risk of amputation, but in the follow-up trials with canagliflozin, it did not show that. Some of the other things more rare, Fortinase gangrene, euglycemic DKA, and then the hypovolemia and hypotension, which we'll touch on a little bit, how to avoid those in this next slide. So when you are prescribing them, you're going to want to follow the labs because they are working on the kidneys, but you will expect a bit of a drop in the GFR, similar to what you see when you're starting ACE or an ARB on somebody. But it is important to note even patients that are on ACE or ARB, you're still getting some renal benefit from these medicines. For patients that are on a thiazide, some of the kind of commentary I've heard, and this I don't believe this is guideline. I think that's more just expert opinion. You can consider holding it or reducing the dose when you're starting these medicines, because you can get a blood pressure lowering effect with these and diuretic effect with them. So to prevent overdiuresis or hypotension, backing off on the thiazide when you're starting them. And another thing that's important to consider is you don't want to start these in patients that are severely uncontrolled diabetics. I've got A1C of over 10 on here. Again, that's not guidelines, that's more expert opinion. Because you're going to run a risk of overdiuresis and euglycemic DKA when you get patients that are sitting at a very high blood sugar. Take home points for this section, SGLT2s, maybe not completely as a class effect, but most of them are showing significant renal and cardiovascular benefits in your diabetic patients. We've got empagliflozin and dapagliflozin now that have shown benefit in heart failure with reduced ejection fraction, regardless of if the patient's diabetic. And we are starting to see some coming out about chronic kidney disease, regardless of diabetes. But you do want to consider cost. How's the time doing, Megan?
You got about 10 minutes.
Okay. So I forgot my potpourri section. I had a few articles I was thinking about doing, ended up being just one. So I don't know if potpourri is the best way to describe it, but I thought this was pretty interesting. I'm sure we've all dealt with patients that have got chronic venous stasis and they won't put their legs up and they won't wear compression stockings and they want something done about it. Maybe somebody else knows, but I don't know if much else good to do. But anyway, this trial maybe can help you persuade them maybe a little bit. I don't know. This was a randomized trial. It was not blinded, that looked at patients with chronic venous stasis or chronic lower extremity edema with recurrent cellulitis. So over 2 episodes in the past 2 years. It was a relatively small trial, only 84 patients. In the control group, they did probably what we're all doing is just education, give them a handout on the edema. Now, one thing that is worth noting, in the control group of patients, when they did have their first episode of cellulitis, they did cross over to the intervention group, which was the leg compression group, in addition to education. They followed them for just under a year, it's about 11 months, and we're able to show a lower incidence of cellulitis recurrence in patients wearing compression therapy. Now, obviously, it's easier said than done to get these patients to wear compression stockings, but I think it's may be helpful in having that discussion with them to let them know that there is some data out there that they may have lower infections if they would be more willing to wear these stockings. All right. Lastly, hotly debated topic, and again, maybe not the most pertinent for long-term care, but in your geriatric outpatients, lipid management. So this was the kind of trial that I heard about that kind of got me looking a little more into it, and thought was pretty interesting. So this was a retrospective trial looking at primary prevention in older adults with statins. The outcome was all-cause cardiovascular mortality. This was a VA study, so it was large, but as you can see, over 90% male and white, just based on the VA population. And at baseline, all of these patients were free of cardiovascular disease. The exposure they were looking at was a new statin prescription. So it did not look at how long they were on them. It was just whether or not they were prescribed a statin at any point during the follow-up period. They followed them for about 7 years and were able to show significant lower all-cause and cardiovascular mortality in the statin group. So I thought that was pretty interesting, because statin therapy is always debated, and especially in older adults, especially in primary prevention. So I thought this was a pretty interesting study. And this is the results from it. As far as the secondary outcomes go, you also saw significant decrease in the cardiovascular disease composite score and in the rate of CABG and PCI. So kind of I put in, there was actually several other studies that came out, I guess, pro-statin in older adults this year, and those were, the citations for those were also included in the handout. Kind of arguing against statins, on the other hand, was, we're not comparing the same thing here, but this was looking at cholesterol levels, association of survival to age 90. A prospective trial, this was all females, as opposed to the last one. It was majority males, mean age of 73, and they were excluded if they had cardiovascular disease, cancer, or were already on a cholesterol medicine. And what they were looking at in this trial wasn't the medication, but instead was the HDL and LDL cholesterol levels. And they followed them until the patients reached 90 or until they died. And they did not see any improved survival with higher HDL or lower LDL levels. And they even noted that that higher LDLs predicted a healthy survival. So I don't know what to make of that exactly, but again, not really comparing apples to apples. This one was looking at cholesterol levels and not statin use, but definitely still some conflict in this regard. I believe this is the last one, and I think this is a pretty good take-home message for statins. So it's looking at the time to benefit of statins for primary prevention. This was a meta-analysis of 8 randomized controlled trials looking at primary prevention with statins in older adults. And it was looking at the time to benefit to prevent the first major cardiovascular event. It was looked at a lot of people, over 65,000. It was a little younger cohort, so 55 to 69, just a little over half, about 2/3 were male, and again, no cardiovascular disease, so just primary prevention. Mean follow-up was 2 to 6 years. What they ended up saying was that for 100 older adults, you would need to treat with a statin for about 2.5 years to prevent one event. So not getting a ton of short-term benefit when you're starting these medicines. So my take-home point for that one was, in patients with a lower life expectancy, which I think you could say is the majority of your nursing home residents, maybe. There's probably not too much of a benefit to starting them on a statin for primary prevention if their life expectancy is less than a couple of years. And the evidence for statin, that I don't think that first study was by any means definitive, saying that there's, we need to be putting all of our older adults on statins for primary prevention. But I think it's worth having the conversation with your patient that even if they're healthy, there still may be some benefit to get on a statin at older age, especially if they've got, especially if they're healthy and have a longer life expectancy. And I think that is it. In the slide set, all the citations are in the notes section, and then again, they're provided all in the handout as well.